I'm going to start, and you guys all have heard my introduction before, so we won't introduce me again, but we're going to focus on intervention mapping now. And you can see we kind of have intervention mapping related to theory and outcomes up here on the title slide. Like I said, I'm going to go through a little bit of lecture-y piece, but please just jump in and ask questions as we go along if you have questions. And then Kiana is going to lead us through some activities around intervention mapping. So as a recap, for those who may not have been here at the talk last week, we kind of introduced the idea of intervention mapping from if you have interventions and outcomes that you, or you have an outcome that you want, and you're trying to figure out how to change that outcome from an outcome that you didn't want, you need to come up with what were the causal factors that made that outcome occur, and then develop an intervention to change those causal factors in the hopes that you change the outcome. And so I gave you this, which I was very proud of, these animations where, you know, you could talk about trying to ring a bell as an outcome, and you could use a bow and arrow, and that works, right? As long as you're a good shot and have some good aim, you can shoot an arrow at a bell and you could ring it. Or you could use a mallet on the stone piece, and then that stone go up. See, I don't know if people who didn't see this are just so impressed with that animation this week. It's good. I like seeing the smiles and the head nodding. But so you have these two things where we can map, you know, hey, if I'm in a community that has a bell and what we have for resources are bows and arrows, we can make that work. And if I'm in a community that has resources that are mallets and stones, we could make that type of thing work too. But we all know that there's an intervention, either a bow or a mallet, there's a mechanism or a causal factor, the arrow or the stone, and then there's the outcome, the ringing of the bell. Okay, one of the things we also talked about was the potential of having a mismatch. You know, sometimes we can have a mallet, which we know can ring this type of bell, because, you know, we have a little stipulation that you probably couldn't get the mallet all the way up there. Maybe you could throw it at it, but you couldn't really get it all the way up there. So you have to work through one of those patterns. But if you mismatched and put the mallet with the arrow, even though the arrow could ring the bell, the mallet is unlikely to deliver it with the level of force and aim necessary to be able to do that. And if you tried to use a bow for the stone down here, it's really unlikely that you'd be able to get it to work. And so this is really just to demonstrate that you can have an outcome that you want to achieve, and you can have causal factors that can make that outcome achieved. And if you pick the wrong intervention to address that causal factor, you might not have any impact at all. But if you match up the intervention with that causal factor, the likelihood for having an outcome is much higher. So let's put this into something a little bit more simple and practical. So let's say that as Bunny was talking about earlier today, that knowledge of what someone needs to do for physical activity was considered to be one of the factors that she thought needed to be changed to get people to be more physically active. So let's just do a little test here. Go ahead and you can type it in the chat. What type of intervention would you match to knowledge to try and get a change in whatever outcome it is that you're looking at? Teaching from Kate, good. Education from Heidi, perfect. And so I used, I actually even had a little thing here. So the desired outcome is to decrease consumption of unhealthy snacks for adolescents, right? And so I picked the word curriculum. Okay, so we'd design a curriculum that would increase knowledge of what's healthy and what's unhealthy. And because, you know what, those adolescents, we all know if they just know what's good for them, they're going to do it. And away we go, right? But we could have a conceptual model that's a little bit more complex. This is still pretty simple, but a little bit more complex, right? That maybe it's knowledge and access to unhealthy snacks that might be the things that would make the change. And so let me see if I've got, yes, I do. Okay, so what would you guys map to at this time? You can either, guys, there's only 12 of us, so you can either talk or type it in. What would be an additional intervention you'd put in there?
Well, you could substitute, you could put in fruit, give them access to fruit.
Okay, look at access to fruit. Excellent, Kate. And look at Rebecca. Is it Slitkowski? Is that, did I say that right? Slitkowski?
Yeah, it's Slitkowski. That was really close.
Excellent, thank you. Yeah, right on the nose. A carrot, not a stick. That's very funny. Although I think also meaningful there, Abby. So what I put here is, well, okay, maybe we continue to have the curriculum because maybe knowledge is necessary but insufficient to change snacking behavior. And so maybe we just put in only healthy snacks in the vending machines. So Rebecca, we were right on the same wavelength. And so we change access, improve knowledge, and then hopefully we get outcomes. And this at its core is what intervention mapping is. Okay, we start with our conceptual approach, and then we match our strategies to the causal factors in the middle here. Sometimes we call those mediators, sometimes we call them mechanisms. And then by changing those mechanisms or mediators or causal factors, we get a change in the outcome. So of course, that was pretty simple. When we start talking, and we've had some sessions here on dissemination and implementation science, we can have different types of causal models. And so this is the IPARIS framework, which is the Integrated Promoting Action on Research and Health Services framework. And you can see that it has a number of different constructs. And so if we're trying to intervene to change the uptake of an evidence-based intervention within some setting, whether it's community or clinical, there's a lot of stuff that we can consider. And all of that stuff provides us with opportunities for mapping intervention to change outcomes. So I'm going to stop here and see if there's any questions, comments, or smart remarks.
I have a smart remark.
Okay.
I love this stuff, but I will, Heidi said she has nothing. Oh, but I always have a smart remark. Back in the day, and I got my doctorate before 1998, you know, they didn't let us look at all the stuff at once.
Yeah.
You know, it was really, you had to have just a direct line between, you know, your desired outcome and one. And so you would look at one piece of it. And I use as an example, a lot of the literature that was done on the chronic care model would look at, okay, let's study decision support. Let's study, you know, social utilization. Let's study, you know, and so the beauty of these and the beauty of the thing I get excited about with this is that the world is allowing us to recognize the complexity of reality.
Absolutely right. Thanks, Kate. That was actually a smart remark, as in intelligent. That was very good. Thank you. Okay, so I'm gonna move us along, and I think last time I also talked a little bit about REAIM, which gives us our outcomes that we talk about in dissemination implementation science. And for a quick recap, reach, effectiveness, and maintenance can all be operationalized at individual level outcomes. So the reach into your intended audience, the effectiveness of your intervention in changing your health outcome, and then the maintenance of those changes in health over time. And then it also can focus on the adoption, implementation, and maintenance of your evidence-based intervention within the setting that you're trying to get it adopted, implemented, and sustained. And so with each one of these outcomes, we talked last week a little bit about, we can map the intervention. So on this one, I don't have our causal factors in there yet, right? I say, hey, we have an intervention, an evidence-based intervention that's going to effectively increase physical activity if we use Bunny's example. So we've got her intervention that we know will change physical activity behavior and sustain that. She didn't present a whole bunch on reach. How well did it reach into the intended audience? That would be something else that we'd want to do. But typically your evidence-based intervention doesn't focus on reach. It's usually you need to come up with dissemination strategies. So when I'm talking about reach, what's another word for a dissemination strategy that you would use to enhance reach into your intended audience.
Communication strategy.
Communication
Social?
strategy. Yep. There's even a more basic one than that, Abby, that we use. Everyone that's ever done a study will use this terminology.
I probably know it.
You do. You absolutely do. And it's probably so simple.
Scale, I mean, we talk about going to scale.
Going to scale, that is related to reach as well. It's just recruitment, right? It's your recruitment plans,
okay.
right? A dissemination strategy to enhance reach is your recruitment plan, right? You're recruiting people that from that intended audience. And typically your evidence-based intervention does not come along with a recruitment plan, right? If I'm doing diabetes prevention, which is stuff that I do, I have a great diabetes prevention intervention that tells me everything I need to do to help someone start to change their behaviors, lose weight, and prevent diabetes. But it doesn't tell me anything about how to get them in the door to get this thing. And so we end up having dissemination strategies that focus on reach, and the same with adoption, right? A lot of times we have these implementation strategies and quality improvement where we'll say, hey, here's the protocol and the process, and that's going to help us implement this in a high fidelity way and hopefully sustain it. But we also, I didn't mean to go there, we also need dissemination strategies that focus on getting more settings, taking it to scale, Kate, but not necessarily at the participant level, taking it to scale at a community level or at a clinical level, where we're looking for, instead of just going into one clinic, we're going to 5, 10, 50, 100. So there's all these different types of strategies that focus on different outcomes. And so we want to make sure that we're mapping the strategy or the intervention to the outcome. And then we use the complex model that I showed you before, and we can start to do this again. So we know a dissemination strategy is it that if people in the intended audience look at your intervention and they think it's better than anything they've seen for an outcome they want to change, they're going to be more likely to engage with that or be reached, right? If they see it as compatible with their lifestyle and the resources that they have, it's going to be more likely, and I'm going to move this to adoption. I'm sorry, I'm talking about adoption here. From a clinical setting, if it works with my workflow, then I'm going to be more likely to adopt and implement an evidence-based intervention. If it's very complex, I'm going to be less likely to adopt it. If I can observe the changes that it's going to achieve, then I'm going to be more likely to adopt it. If I can't see the outcomes, then I'm going to be less likely to adopt it. So I could go through each one of these innovation characteristics. And so the question is, what type of intervention do we use? And this again is using Jenny Hill and Kate Heelan's CDC grant that they were focused on childhood obesity treatment. And their first dissemination strategy in that project was to package an evidence-based approach for easy uptake in small towns and rural communities. So they made everything into an electronic blueprint that a community could just press the button, start here, and they would have all the resources and trainings and materials necessary for them to implement a community program. And so that's mapping, right? So, hey, we want to improve the advantage of what we have. We want to make it compatible. We want to make it less complex. And within that dissemination strategy, they also packaged ways to track outcomes, to be able to test it out a little bit. So all of these things are addressed with this particular strategy. So the goal is that you have a strategy that improves the causal factors, the mechanisms or the mediators, and those lead to a higher level of adoption. In this case, it would be, adoption in the number and representativeness of communities. Okay, any comments on this one? I'm gonna go through another one from their study.
Well, I was just thinking of an example too, Paul. In Minnesota, we have a project called 10,000 Families, where the aim is to collect actually biospecimens on, thousands of people in Minnesota. But you want to get a really good, a really good sample, a diverse sample. And how do you convince people to hand over their blood work and other specimens that are very private? And if you don't have people from different cultural groups, for example, you're not going to learn what it's going to be a very skewed sample. So the dissemination has been the biggest part, the recruitment, the biggest part of that project, to try to help people understand and bring people along and do it in a community engaged way to get people excited, So it's been a huge challenge, but if you can take a step back and say, all right, this is the piece we're really going to have to focus on, because it's the most important part of the project, this initial recruitment, so you have a good sample of people that's diverse. You don't leave anybody out.
For sure. And so that's the outcome, right? You want the diverse sample within that biorepository. And so then coming up with what's the conceptual model that would enhance the diversity within that repository. And one factor within there could be, kind of leveraging social norms related to providing this and enhancing perceptions of community value in that. And so then you can come up with community engaged approaches as your strategy that would lead to improvements in leveraging the social norms, or even changing some social norms potentially, and identifying what value the community would see in the utility and application of that repository. And by getting community generated values and then using that within your recruitment approach, you would hypothesize that you'd have better reach and more representation. So that's a great example. So I'll give you one more example from Kate and Jenny's project. Another group of constructs, you saw that up there. We have inner context, so things within the implementation setting, so where the things are going to be done, whether it's a community organization or a clinic. And then we have the outer context, that all the things that might influence that clinic. So whether it's policies or incentives, when I think healthcare, I think a lot about the Affordable Care Act and, a lot of incentives related to population and public health activities there. So those things can lead to better implementation, right? So if we use implementation as our outcome here, meaning like fidelity, implementation quality, can we come up with things that can change these factors or leverage the factors that are there? And so in their project, they used a systems-based learning collaborative. And I know many people in healthcare settings have used learning collaboratives. IHI really kind of brought those to prominence. And in their project, they used what they call a systems-based learning collaborative that included having communities engage with them. But within the communities, they had to have organizations that would do implementation, organizations that would focus on recruitment, and then they had to have decision makers and doers in each of those communities as part of the learning collaborative. So they really focus on kind of horizontally across the community, things that are needed to get a childhood obesity intervention in place, and then also vertically within each of those organizations to make sure they get practical information from the doers, like the practitioners, as well as the people that can make the decisions on what would be done. And so that makes it an intervention approach that can really address a lot of these inner context factors and pull in some of the outer context factors because of that broad horizontal across community approach. So that's a pretty straightforward ones. Now, I'm going to give you, and this one, Shannon, I just saw that you said recruitment. You were right. You're right. Anyway, what I wanted to walk you through now is this is that same project, and Kate was saying earlier how she appreciated that now we're allowing ourselves to embrace the complexity of reality, right? And so when we do that, our intervention mapping becomes a little bit more complex. This is what's called an implementation research logic model. And it's relatively new. J.D. Smith and his colleagues put this together. But the idea that they had was, hey, you know what we need to start with is we need to start with this complex context, Kate, that you were talking about. And we need to identify drivers and barriers, or barriers and facilitators. And we need to think about this context because it's going to influence all of our implementation strategies and everything that moves forward. And if you look closely, you'll remember from the IPARIS framework, these barriers and facilitators are based on that initial conceptual model. So this just kind of, the intent of this column is to give you an overarching sense of the context within which you're trying to get your evidence-based intervention adopted, implemented, sustained, and have high reach and effectiveness. And so then within this context, the next thing that we did on this project was we started with the outcomes. Oh, where did that go? There it is. So we started with outcomes. So the first thing that this project was focused on is how do we get rural communities and small towns to adopt an evidence-based childhood obesity treatment intervention? Right. And so we operationalize adoption as the number of communities that agree to deliver. BHF stands for Building Healthy Families. You can see over there on the nice logo. And then the number of Building Healthy Families cohorts that are initiated. That's the outcome. Okay, so we're looking for how many communities, what types of communities. And so we start with the mechanisms, right? We talked about this before. So now here's the things. We think that we need to have some sort of incentivization. There needs to be some incentive for a community to even consider starting this type of intervention. We also think that communities need to have some level of readiness for implementation, and that kind of includes community capacity, and that there needs to be some sort of mandate for adoption. Okay, so these are all mechanisms, right? All the things that we think would lead to higher adoption. And so what's an implementation strategy that can do that? Basically within the study, we used an RFA process that when you talk about implementation strategies would be defined as a fund and contract approach, which helped us to identify communities with strong partnerships across organizations and a priority to address childhood obesity. With that, we gave them a little bit of money and a memorandum of understanding that gives that little mandate for adoption of what they're going to do as a result of having those resources. And then we'll monitor adoption, right? How many of those communities ultimately initiate a childhood obesity treatment program? But of course, we've talked about REAIM before. Oh, no, I'm not even going there yet. But there's other things too. So I guess, again, we could also think about others. And I'm not going to go through each one of these mechanisms, but you guys can see what I've done is I've kind of color coded here. Anything red, we believe, is ultimately leading to the adoption outcome. Anything blue, you're going to see in a second here. You can see we have that, remember this is that packaged blueprint that we put together. We believe that's going to increase adoption, but we also think it's going to hit some of these factors. Oh my gosh, look at how I should have reviewed my slides before I started. I'm going through a bunch of mechanisms. So we can have a lot of mechanisms for adoption, but as Kate was pointing out before, mechanisms for adoption might also influence other outcomes as we come up. So just don't think of anything except for being all red right now, right? And so we can see that within here, there ends up being a number of implementation strategies that are all mapped to the different potential causal mechanisms, mediators, and those are thought to increase adoption. Okay, so you're probably much smarter than me and are anticipating that the next button I click will give you a blue box, and you're right. And so for this one, we focus the blue box. Any of these intervention strategies and mechanisms we think will enhance implementation and reach. So we put those two things in together here, and we see that some of them, the fund and contract, probably won't influence implementation, will probably influence adoption, but not implementation. But these other ones have different levels of impact or different outcome impacts. And then we can think about, and you knew it was coming, a gray box. So maintenance, and within the Action Learning Collaborative, you can see there's a sustainability action planning component to it that works through these mechanisms that would lead to maintenance. And then of course, at the very end, we want to make sure that we have effectiveness and help families with children that are overweight or obese reduce their obesity or their child's obesity. So we look at effectiveness in terms of reduced BMI-Z scores, parent weight loss, and then the maintenance of effect. And in that one, we know that attendance, increased physical activity, improved healthy eating, goal attainment, and self-regulation are all of the mechanisms that would lead to effectiveness and maintenance. So all we need to do is think about, well, what's the intervention that we can map to those things, and that's building healthy families. And you can see a little bit of the description here. So when we talk about intervention mapping, it doesn't just have to be a bow, arrow, bells, and a mallet. It doesn't just have to be A to B to C. We really can think about these complex interventions that have multi-leveled outcomes. And we can put all of that together to try and map out the best possible set of strategies that will change what we think are the best possible set of mechanisms that will then lead to the outcomes that we'd like to achieve within a community. And thinking of these broad re-aim outcomes as demonstrating potential public health impact or population health impact. Okay, so I think I'm almost done all of the examples here. Any questions on this one? Did I completely put people to sleep? Okay, good. I noticed a couple cameras went off, so I figured they must have just laid down. Decided that was enough. Oh, and then, oh, sorry, I did have another click here. You can see it up at the top, when we talked about our theories and frameworks before, remember when we talked about dissemination, implementation, science theories and frameworks, you can see the explanatory theory really fits within that, the mechanisms and providing your context, and then you have your outcome framework at the end, outlining obviously the outcomes.